The next session will be about moving the mountain in health systems reform perspective from Australia. So we all very curious to know how to move the big mountain in Australia. And our guest speaker today is he actually is the former CEO of the Sydney Hospital and the CEO of the area health services in rural area of New South Wales, and he turned to be the academic. He is an adjunct associate professor, School of Rural Medicine, University of New England, Australia, and he is an internationally recognized public health system manager who has had intensive consultancy experience across Australia and internationally in the Asia Pacific, including Thailand, in the accreditation and quality management of health services, the development of health service managers, and the management of health systems, and in the delivery of primary health care services in rural and regional settings. And recently, he was appointed as adjunct professor of college health systems management at Naresuan University in Thailand. He also is the editor of Asia Pacific Journal of Health Management and president of Society for Health Administration Program in Education. And also he is the director of the Primary Health Network in rural area of Australia. Please welcome Adjunct Professor Dr. David Brick, please.
I must say it's a great honour and privilege for me to be here today in front of you all and in front of all these distinguished, very senior and experienced Thai health professionals. So you do me a great honour. I think the introduction I've had is does me more great honour than I deserve, but I'm very pleased to be here. I've been coming to Thailand. My first visit was in 1995, and I've been here pretty regularly ever since, over a long period of time. And on that first visit, I met Professor Pachet when he was at the ministry, and we've remained great friends ever since. So I have a bit of a love and a passion for Thailand and for Southeast Asia. I think I realised years ago that Australia, no matter that it's a great country, is in many respects a small country, and healthcare was going to become globalised, and it was important that Australia be part of that global development of health services. So hence my interest and the fact that I worked in and around Asia for the last couple of decades. I must say that I met Dr. Pudit, I think more than a decade ago now, and he came to talk to me about setting up the profession of health systems management in Thailand, and I found him to be a very passionate and committed health professional, and so we started working together all that time ago, and it's really special to see the establishment of the college in Thailand. I was involved in the establishment of a similar college in Hong Kong some years back, so it's good to see that we're developing this global network of health professionals interested in health systems management. Now, Pudit asked me to talk slowly, and contrary to his opinion, oh, yeah. Which way? Yeah, okay.
Excuse me, may I interrupt you? I asked Professor David to speak slowly and not go to the low voice.
Am I doing well?
Yes, you are doing very well. Thank you, Professor.
I have a bit of a dry throat, I'm sorry about that. But contrary to Dr. Pudit's view, he said, I don't speak English, I speak Australian. And you'll notice I have the Australian broad accent. So he's my interpreter. So if you don't understand Australian and you want to understand it in English, ask him. So, let's see if I'm not sure that I can do two things at once, but we'll try. When I was asked to speak, I said, what do you want me to talk about? And they're all the things that Dr. Padit wants me to talk about. So this is going to be a long session. But it won't be really, because a lot of it's just for information for you to take away. But I hope by the end of the session, there might be 4 or 5 takeaway messages for you. When I make these presentations, I always say, I'm not here to represent the Australian system as excellent or better or the way everyone should run the health system. All I'm doing is describing the system, describing the good parts and the not so good parts. And I think there's a lot of value in us all comparing our health systems. I learned my profession by comparing what happened in different states of Australia, in different hospitals and different parts of the system. I've learned a lot from working in different countries in Asia Pacific, learning how they do their health service. And I go home and I say, do you know what Thailand's done? They've done this and it's really great and we should think about it for Australia. So my presentation is not about we're good. My presentation is about comparison and reflection, and people pick up on things that interest them or are of value to them. Australia's had a lot of health reform over a long time, going back to the 1970s. We've been reforming the health system. And at one stage there in the early 2000s, we said, we're reform weary, we've had it, we're just changing the system all the time, but nothing changes. So the first point to make, if you're going to reform the health system, there needs to be a problem to be solved and challenge to be addressed, an improvement in outcome, and we don't want changes for change's sake. So the question is, what are we attempting to achieve? What is the problem we're trying to solve? What is the critical issue? So if you're a good health systems manager, that's the way you think. You question the reality we're in, and you question the policy and the direction that's proposed so that you better understand it and can have better health reform. Now the mountain is in the title because of respect to Professor Wasi from Thailand, and that's his motto about moving the mountain with the triangle. So that's how Padit and I came up with the heading of the talk. One of the biggest problems in Australia is that we're a federation, a commonwealth, and that means that the states of Australia, New South Wales, Queensland, Victoria, were formed before Australia was formed. They have their own constitutions, their own governments, and they set up the constitution to become Australia. So the states in Australia have a lot more power than, say, your provinces. We're a federation of about 8 states, okay? That creates problems in delivering good health care. We have 3 levels of government: Commonwealth, state and local government. Everyone likes to live at the beach in Australia on the coast, so highly urbanised. 24 million people, 27% overseas born, and about 3% of our population are the first Australians, the Aboriginals. So the map of Australia on the left-hand side, I put that up really just to show you where the population lives. So the shaded areas are where most of the population lives. If you've not been to Australia, there's a lot of desert land in the centre, and there's people living there, but there's no concentration of population, okay? The other map, which is the map of Australia, shows how big Australia is geographically. And in fact, if you look at the top right-hand side, you'll see Thailand fitted into that part of Australia. So 60 million plus Thais in a small part of Australia, 24 million Australians, a number of them who are Thais, spread right out across the nation, okay? So it gives you some idea of the distance and the geography, and Australia is a big country in terms of its size. population, the chart on the left-hand side is the Australian population. And the thing you'll notice about it, it's an ageing population. You see it's bulging, starting to bulge out up towards the top. So our population's getting older. The chart on the right is the Aboriginal people, right? And you'll see that they're not ageing. They're a very young population. So we still have poor health outcomes for Aboriginal people for a whole variety of reasons. And we're desperately trying to close the gap, bring their health up to the health of the average Australians. Big challenge for us. But, as has been said before, Australia has a good health system, and the figures tell us that's the case. And you can see our death rates are declining over time. On the right-hand side, the causes of death are listed there. So they're the diseases of a developed country. Our overall mortality rate is one of the lowest in the OECD countries, which is the group we compare ourselves with. Only second to Japan. We've had great improvement in the cancers, although within the cancers that's variable. COE deaths have decreased. And we're getting better results with lung cancer, coronary heart disease, breast cancer, and suicide continues to be a problem. Diabetes is a bit of an epidemic, an issue in Australia, and we're part of the obesity epidemic as well. All good young Australians becoming very large and not very active. So we have that significant problem which is going to impact on the health system. So we've had some areas where we've gone backwards, and they're listed there. I won't dwell on them at the moment. So this is just another representation of the structure of the Australian health system and who does what and who funds what in the system. The Commonwealth Government, they collect the taxes from the Australians. Most of the taxes, the states have some taxing but not much. So the Commonwealth Government gets all the money and it funds the states and territories to run services. The states run the hospitals, community health and public health, right? And they've always been in the context of, or for a long time, being delivered through area networks, through districts. So we've systemised, that's the important word, we've systemised our healthcare delivery into geographic regions. Local government looks after the basic water, food, buildings, sanitation and roads. Because of the Constitution, the Commonwealth funds primary health care directly. So the states look after the hospitals, the Commonwealth looks after primary health care directly. So there's a problem for a start, because you've got two different levels of government delivering parts of the health system, and we're meant to work together, okay? The Commonwealth funded primary health care through what we call divisions of general practice. Then we were reformed and restructured, and I'll talk about that later, into Medicare locals. And last year we were restructured again to establish primary health networks. So we've had 20, 30 years of change in primary health care over that period in the different structures, and I'll explain that later. So the Commonwealth funds and reimburses general practice and specialists directly and through the patient, and again I'll talk about that further. It directly funds aged care provision in Australia, and it delivers and manages Medicare, our health insurance system, subsidises private health insurance, and provides pharmaceutical benefits, subsidies and schedule, and the medical benefit schedule, which is the items that doctors can charge patients for. So the Commonwealth has a very important role in what I think is the most important part of the health system, and that's primary health care. So, I guess this slide again encapsulates the complexity and the difficulty of funding health systems in Australia. Governments of all persuasions spend 70% of healthcare expenditure. So 57% of that goes to public hospitals. The Commonwealth funds 40%. The states fund 60%. As I said, we're spending a lot of money on Aboriginal people to try and rapidly increase their health outcomes and status. And so we're spending more money on them than we do the average Australian. And we've had a lot of increased expenditure because the government and the community wanted to improve the health outcomes of Australians, and immunisation was the major national project to make sure that everyone was immunised in Australia, and we've got very high immunisation rates. So the colour chart tries to tell you who funds what and who delivers what. Okay, but I think I've given you the basic outline there, but you can have a further look at that. Again, that's where another side of where the money comes from and what it's spent on. This slide over here is important because that's the three levels of government, and that's them funding a range of services, and you can see there's crossover and interaction between where the funding comes from. So it's not clear and simple, it's messy and confused. So that's what we deal with every day of our life. We've been very good at controlling our health expenditure, and it's currently about 9.7% of GDP. And it's, as you can see, it's on an upward increase, but we've managed to slow it, contain it fairly well over the last decade. And so much so that the Australia there in the chart of all the different OECD countries, we're one of the better performers in terms of our expenditure by GDP, and you can see the countries who spend a lot of money but don't necessarily have a better health system. Again, that shows you where the money, another way of showing you where the money goes and who funds it. And I'm not going to go through it because it's just there for you to take away. But a substantial expenditure on public hospitals and primary health care. In terms of what the money's spent on, you can see cardiovascular disease, the main areas of expenditure, oral health. In oral health, there's a lot of private funding, you know, people pay for a lot of themselves, and so on. And mental health in a country that's, has a sunny disposition, and we're all very well off, we still seem to have increasing problems with the mental health of our communities, and so on. So that's for you to have a look at and compare it with the circumstances in your country and see the similarities and the differences. So, I just want to talk a bit about the drivers of expenditure. And this is from our literature in Australia. Expenditure on adults aged 85 plus is said to be almost 20 times as high as expenditure on children aged 5 to 14. Well, I personally say, well, that's the way it should be, shouldn't it? Children are generally healthy. Older people with chronic disease and all the rest of it, and the burden of age, might use services more. Although my view is that a lot of older people are healthy or they're resilient and put up with disability and some chronic illnesses and don't necessarily use the services. And there's evidence that their use of services is being extended out to later in life for a shorter period, but a more acute episode. So the politicians and the policy people are convinced that ageing is a problem. I don't think it should be seen as a problem. I think it should be seen as a challenge, certainly, but not a problem. But I think politicians and others like to demonise issues so that we all get concerned about how we're going to pay for it and how we're going to look after people, so forth. So I think the evidence on that, our next speaker might be more understanding of the issue, but I think the evidence is still out a bit on what the impact of that's going to be. But there is an impact. Technology and research means that we can do more things to more people and have more opportunities to help people than ever before. So the boundaries of the health system are being driven by technology and innovation and potential to do more, while at the same time helping us to do things better. It's generating growth in the utilisation of the health system. So whatever way you look at it, health expenditure has risen faster than either the population growth or ageing. And our government in Australia, this is their second term, is, I don't know if you have right-wing or left-wing governments in Thailand, but our right-wing, our conservative government is a bit, the Liberals are a bit market-driven. They like the American system, and they want there to be more competition and purchase funding, this type of thing. The left, the Labor side of politics, they believe health is a public good and we should be funding it as part of our contribution to the well-being of our nation. So there's tensions. And we just had an election and the right-wing people, the Liberals, won by one vote. So, and they don't control the upper house. So that means probably not very much is going to happen in Australia for at least the next term of government. So we're talking about 147 billion in 2012. Growth was about 5.1%. Non-government spending grew by 7.2%. So what that means is the government's pushing the cost of care away from itself to others, back to individuals, because they don't want to raise taxes. So we spent about $6,500 on per person, and that's actually less than we spent back in 2012. So we are controlling and slowing the cost of healthcare. So I was asked to talk about Medicare. We have a national health insurance system that's known as Medicare. We do not have a national health system. So there's a distinction there, okay? Medicare was introduced quite a while ago and different governments have supported or tried to restrict it. So it's on the political agenda, it's still contested. But Australians love Medicare, they believe it funds all their healthcare services, and they very much support it as something they are entitled to. In the last election that was contested, and I'll talk more about that. So Australia has a high sense of ownership of Medicare, and Andrew Podger, who's a very eminent Australian policy maker, said that the system should have these key principles: universal coverage, which you people know all about, making sure people have access to services; equitable financing, have to be funded according to people's capacity to pay, and we're currently debating that in Australia again. It should be efficient and effective in terms of health outcomes. So that means measuring and evaluating and proving that we're making a difference. And it should provide consumer and provider satisfaction. So it should be orientated to patients and consumers and respecting the professionalism of those providing the service. And we've been through a bit of a decade where the value of health professionals and the importance of what the community wants has been diminished a bit by the political agenda. So there's a lot of us trying to get back the public interest and the balance about what we want in our health system and the fact that it's our health system. So it's a very important public policy agenda at the moment. So that card is what your Medicare card looks like, but actually it's an ad by an activist group in Australia saying the current government is trying to privatise healthcare, and they're saying that they've frozen the rebate to doctors for Medicare. It hasn't risen for a couple of years. The money the doctor gets paid by the government. They don't even get a CPI increase. So the doctors are running a business, but their funding hasn't increased. So very contested issue with the medical profession, because if the doctors don't get their money, they charge the patients more, which means access becomes a greater problem. Fees have gone up for pathology and radiology because the view is, and probably supported by the figures, that there's overutilisation of pathology and diagnostic services in Australia. And they've actually taken some of them out of the medical benefit schedule, so you can't get reimbursement for them. They say they privatised Medibank. Now, Medibank was set up by the Labor government as an insurance fund for people to have private health insurance. So, but there are plenty of those private health insurance funds in Australia. So the Liberal government sold it off to get the money to invest in other services and reduce debt. And they tried to force a co-payment to be made for all GP visits. So when you go to the doctor and you pay your $70, they want the patient to pay another $10 on top, and the government pay no more. So shifting the cost. The doctors resisted it, the public resisted it. It hasn't happened. But if the doctor bulk bills you, you pay nothing. And a lot of the doctors bulk bill. If they don't bulk bill, you pay $70+ a visit, and you only get about $30 back from the government. So you're paying $40 a visit. So that. Yes, I think I'm coming. So depending on the doctor you go to, you can get free care, free service, and they just accept the money from the government, which is less. Some doctors won't do that, so they charge you $70, you get $30 back. If bulk billing means you go with your card to the doctor, and the doctor sends the bill straight to the government, and he gets his $40 off the government, okay? But not most of them. So some do that, particularly in the urban areas where they've got very big throughput, plenty of doctors, they bulk bill. In country areas where there's not as many, they charge the higher fee, and the patient has to pay part of it. And if patients can't afford it, they end up in the emergency department of the hospital to get free care. So it's a real problem. So even though we have universal health care, it's not exactly universal. So a downside to our system. Right, so we pay taxes on our income, whether we're an employee or an employer, company, and part of that is a levy for Medicare, 1.5% of our taxes that goes to fund Medicare, and the general public thinks that pays for the health system, but in reality it only covers about 18% of the money spent in health, so the rest comes out of general revenue. We have the problem of fiscal imbalance because federal government raises the money, but they can't just go and spend it. The states have got to agree and the states spend the money. So that creates a problem, and there has to be a mechanism of agreement between both to make it work, and I'll come to that. We've had the levy since 1984, started off at 1%, increased to 1.5%, and in October a further 1% was added for high income earners who didn't have private insurance. So it was an incentive for high income earners to insure, okay? But if you've got private health insurance like I do, I only pay the 1.5%, okay? Now, the government also, through taxation, subsidises private health insurance because we're a pluralistic society. We have public and private sector working together, and the government believes there's a place for both. and they want private health insurance to be sustainable and to survive and exist in the future. But the proponents of the public system say, but you're spending our taxpayers' money keeping these health insurance funds. Some of them are voluntary, some are profit, going. Why not just put that money into the public health system? So another area of debate about how we should fund is about the insurance approach. Also, some private health insurance funds tend to end up with the most expensive and the most costly patients, and it affects their viability. So there's a reinsurance pool where the government provides funding to balance off some of the inequities in the private system. I'm a bit of a, apart from the financial side of what's ethical and what's good, I'm a believer in private health insurance because it means if I need to go to a hospital, need to see a doctor, I can do it straight away. I can have a doctor of choice, my hospital of choice. If you're just a public patient on the Medicare, you go to your local hospital, the doctor is allocated from the doctors that are appointed to the hospital, and you're treated. And if it's something like elective surgery, hips, knees, and you go on a waiting list. So we have waiting lists for surgery and acute care in Australia, and we monitor how big the waiting lists are to see whether we're managing the workload. So the private health insurance gives some people the freedom to get services straight away. It's the same doctors, like the private, the public system, but they'll see you sooner in a private hospital because you can get in, whereas in the public system, you've got to come up with a criteria and you've got to suffer discomfort and pain before you get operated on. Okay, so that's the difference. And a couple of years back, the government decided we were going to have a national disability insurance scheme. So they increased the levy, the Medicare levy, to pay for that scheme getting set up. And just briefly, it's an interesting scheme because what's going to happen, instead of people getting service from a disability provider and accepting their range of services, they're going to get the person with the disability is going to get a pot of money. They're not going to get the money, but there's money allocated, and they can make decisions about where they go for care. So rather than the system deciding where they go for disability services, the person with a disability will make those decisions themselves. So it's turning the pot of funding upside down and saying the person getting the care will make the decisions about who they get the care from. So that's a significant change in how we deliver services, and it's going to happen in healthcare as well. So, sorry, this is where people did ask me to talk about the bulk billing. So the Commonwealth Government allows doctors to send the patient's bill direct to the government. So when you go to the counter, if you're covered by Medicare, the doctor or the receptionist says, "Thank you very much, Mr. Briggs or Dr. Briggs. You don't have to pay anything. Off you go." If they don't bulk bill, they say, "Mr. Briggs, that'll be $75, and the government will send you a cheque for $30." Right? So then I have to pay that and get the money back. So the system's electronic. You can do those transactions from the surgery when you're there and the payments. But the doctor, in effect, can charge the patient whatever figure amount they like, and the patient either pays it or they go elsewhere. But a lot of doctors, particularly in metropolitan areas, charge the bulk fee, the common fee, and the patient pays nothing. So is that okay for you?
Yes, thank you, Professor.
Right. 2 or 3 governments back, and we've had a lot of different governments in short time frames in Australia. They don't seem to last long. They put a freeze on any increases to the doctors for the common fee, scheduled fee. And the doctors aren't happy because they say we have a business and our costs are rising above the CPI. So that's a point of tension at the moment. The fee is set in the MBS, Medical Benefit Schedules. It says how much the government will pay for each item. Okay. And when you go to the doctor, it can be a short consultation or a long consultation. We are now doing things like care plans for aged persons and program care for chronic disease like diabetes. And the government's trying to change the funding as much as it can to capitation or lump sums for a population of people or a particular illness. But industrially, they're fighting the doctors because the doctors still want fee for service and they don't want to change. So a point of tension for us. Now, you can't have private health insurance when you go and see the general practitioner. But you can have private health insurance when you go to see the specialist and go into hospital, okay? So the government will not allow insurance for the GP fee because they just fear that the fees will go up and that it'll cost insurance companies, the taxpayer, more. Right, so we've got plenty of private health insurance for the hospital system, and as I said, it gets you faster access into the services. And also the private hospitals have done a deal with the health insurance companies to say rather than a patient coming in paying for intensive care, for the anaesthetist and for the pharmaceuticals and for the accommodation, they say for your procedure the total package cost is X. So the patient knows, the insurance company knows that there's no surprises and they're paid and covered for a quoted figure. The other thing they've done is they said for Medicare and for health insurance, if you take on private health insurance before you reach 31 years of age and pay the health insurance, you'll pay a lower premium for your life than if you just signed up for health insurance at 50 because you know you're going to need health care. So there's an incentive being made for people to have private health insurance. So there's been a high take-up naturally with the cheaper rate for people over 31. But when they get around the age of 50, a lot of them start to opt out of the private health insurance because they may be unemployed or they're retiring, or they think, well, if I wait, I can go to the public hospital anyway. So it's starting to drop off a bit. So the incentive's only partially working. So about half of the Australian population has private hospital coverage, and through the private health insurance system. And the private health insurer can be a not-for-profit or a profit-driven company, and the increases in their fees they charge people has to be approved by the Minister for Health. But they also make very big profits at the end of the year, whether they're public or private. And there's a bit of debate going on, well, if they can make profits, why isn't that money going back into the... Why do they need to make profits? Well, they need to make profits because they've got shareholders. So that's the dilemma the government's got. So it's again a question of whether a public system or a private system, or a bit of both. So I'm privately insured, but if I go to my local hospital, I can say to them I want to pay and be a private patient, or I can say no, I want to be a public patient and just use Medicare. So I still have that choice. And in a public hospital, there's not much difference in terms of the room or the bed or the food, all that between the two. But down the road, there's a very nice private hospital, a nice big television, private room. They give you a glass of wine with your meal at night, and you think, well, this is where I want to be, to have my health care.